to the webinar on acute stroke basic and management. On behalf of IAP technical team, I warmly welcome to our resource person, Dr. Kapil Singhal sir. We are live on IAP India YouTube page. During this presentation, if any of you have any questions to the speaker, you can put it in the question answer section or chat box. Now, I request to the moderator, Dr. Manik Dixit sir, to please comment with this session. Thank you.
Thank you, Dr. Himandri. Your sincerity and professionalism is truly appreciated. Myself, Manik Dixit, physiotherapist by profession and currently giving my services as principal in Pacific College of Medical Sciences. Friends, as you know that the new normal is this platform where we are currently all sitting here to learn. This is the new normal post-pandemic, and probably this is going to stay the way it is for a couple of few months or maybe years. We are yet nowhere close to guess that out. So enduring while we are making ourselves safe and healthy, I really appreciate our central leadership, Dr. Sanjeev Jha sir and Ruchi ma'am, under the able headship of state, Dr. Shruti Sharma ma'am, Anjana Tewatia ma'am, Dr. Renu Giri, Dr. Deepika Sharma, and Dr. Anshika Singh for arranging this where we can really learn a lot. Friends, today the topic which we are going to cover for you guys is acute stroke. And no need to say about the social impact this disease or this disorder is making in our society. From the question that Dr. Saab hamara mareez bach jayega ki nahi, the whole story is actually left behind. And to tell manifestations, we have with us legend Dr. Kapil Singhal sir, who is presently working as senior consultant and clinical coordinator in Metro Center for Neurosciences, Metro Hospital. Sir is a prestigious All India Institute of Medical Sciences, New Delhi. He has been associated with G.B. Pant Hospital previously. He has been awarded gold medal for his work during his post-graduation. He has a vast experience in managing all aspects of neurology and has a keen interest in acute management of stroke patients. His other areas of interest includes movement disorder, including deep brain stimulation, epilepsy, and other neurological disorders. Sir has been publication in both national and international journals. He has keen interest in teaching and academic activities. He is a member of various national and international associations. Sir has previously associated with Max Super Specialty Hospital, Vaishali, Ghaziabad. So friends, no need to say that why we have requested Sir to please spare some precious time of his and share with us all the knowledge he has about acute stroke. Over to you, sir. Dr. Kapil Singhal, sir.
Thank you, Dr. Manik, for this brief introduction. I hope I am audible clearly, or I need to put some
absolutely,
headphones.
Sir. Absolutely, you're absolutely audible.
Right. So, as a neurologist in stroke management, patient needs a neurologist for a few days after acute stroke, maybe a few more months at intermittent periods of regular visits only. But the physiotherapist role, the rehabilitator role is very huge when we are managing stroke patients. And I'm highly thankful, highly indebted from my side and from all my patients to all the physiotherapists, you all who have been associated with my patients and a large number of patients for providing constant care, constant support, not only to the patients, but also to the patient's family, for supporting them, for boosting their morale, for being there in their odd times. And we always believe that it is physiotherapists, it is rehabilitators, you people who are going to take care of the patient after a few days, initial few days, and everything, the patient recovery will depend completely on what the patient does, what you people do with the patient. I will again thank all the physiotherapists who have been taking care of the stroke patients and other neurology patients. With this thank note, my aim is not to teach something, My aim is to spread awareness among everybody, among you people, so that this message can be carried forward to the patients, to the families, that management of a stroke, acute stroke management, the acute stroke recognition is very important, and the few initial hours made the most difference in the patient's outcome. And if we are active in the first few days, first few hours, it can be a remarkable change in the patient's outcome, and the further care can be taken care by you all people. So with this note, I will start my presentation, and a few case examples of how a good stroke management team, a good stroke care team can make a difference with the patient's family. What are the usual symptoms, how common this stroke is, and I will request if anybody has to interrupt in between, they can do, or we can go for the questions in the later part of the presentation, after the presentation. So Metro Hospital Noida is the only hospital in Uttar Pradesh, and maybe only one of the 4 hospitals in whole of India which has been awarded with Platinum Award from World Stroke Organization in recognition of the stroke care which has been provided to the patients. It includes everything: immediate CT scans, the immediate treatment, emergency treatment of the patients, following assessment, rehabilitation part, which has been taken care very effectively by Dr. Shruti, and post-stroke care also. And they have set parameters, and fortunately, our efforts have been fruitful, and we are the only hospital, one of the 4 hospitals in India, who have been awarded with WSO award for the last quarter. So a usual scenario: a 66-year-old gentleman who is hypertensive comes to emergency with right hemiparalysis and inability to speak at all, and the symptoms were around 1 hour before presentation to the hospital. So we have this NIHSS. It's the National Institute of Health Stroke Scale, which has got around 23 parameters, which have different numbers, and higher the score, more severe the patient stroke is. So NIHSS of 18 means the patient has a moderately severe stroke, which means that patient is possibly not able to speak at all, or is possibly not having right upper limb and lower limb movements in this case. We'll have a brief look at the patient's video. So this is a gentleman who is constantly looking towards the left half of the body. He's able to flex his left knee, move it spontaneously, but he's not moving his right hand of the body at all. This patient was completely mute, aphasic, with right upper limb and lower limb power 1/5 or 0/5, and his NIHSS was 18. Anything above 12 is a moderate to severe stroke, and his score was 18. Immediate MRI was done for this patient. There's some overlap, but there was a very faint area of whiteness in this MRI, which we call as diffusion restriction, which shows that it's a ischemic stroke due to clot in the brain, not due to bleeding in the brain. We did a MR angiography also. Immediately, what you can see very clearly is that there is this blood vessel which is going to the right, but it's complete cut off on the left side. So there is no blood flow to practically this part of the brain on the left side. We thrombolize the patient with Actylize or clot buster, which is a medication which has to be given in first 4.5 hours of onset of a stroke. This gentleman had come to us within almost 1 hour, and within 30 minutes he was given this thrombolysis. And this is the same gentleman which is sitting next day after thrombolysis. There is some comprehension difficulty. He is still having comprehension difficulty, but he is able to sit without support. He was able to lift his right arm, and he was able to move his right leg also, and he walked out of hospital with minimal support. So suppose we had not done anything in this patient. He had come late, he had come after 6 hours or 8 hours of onset of symptoms, or we just admitted him and did not do anything. The patient would have been bedbound completely without any movement of the right half of the body ever, completely dependent on family, on caregivers for life, incontinent, requiring support even for having food. And this patient walked back home with minimal support. In terms of modified Rankin score, which is a disability score, his MRS was 2, which improved to 1 over a period of 6 months. So this is the patient. His infarct was large. This is a post-treatment MRI, but we were able to save possibly a large area of the brain from here to here and could make a significant improvement in the outcome. And this blood vessel, which was completely blocked here, got recanalized, and that's why we had this outcome. So whatever the clot was present here possibly was removed, and there was a restoration of the blood flow to this part of the brain, which converted into the patient's improvement. Another example, this patient was in Metro Hospital. She was admitted in cardiology, had atrial fibrillation, and was already on heavy blood thinners like acetone, which we call as anticoagulants. She woke up, had gone to the bathroom at 7:30 in the morning in hospital and collapsed. And she had right upper limb and lower limb weakness. Again, this patient is you can see that this her hand falls freely to the right. On the right side, there is no effort against gravity. She again was having this MRI was done immediately. A very faint infarct is seen in this area. We did a CT angiogram, and this is blood vessels which are going to from the heart to the brain, and this is the right middle cerebral artery, and again it is complete cut off here. So after discussing with the family, the patient was thrombolized with IV TPA in the usual doses, and this patient is 1 day after thrombolysis. She is walking without support. She had some residual speech problem, but she came into the follow-up for almost 5 years, and except for some naming difficulty, she was completely normal. These are just a few examples. This is her MR angiography, which we just did out of curiosity or academic interest, and this shows again recanalization on the left side. Another gentleman from Noida area only, right hemiparesis. He's seeing towards left, complete right hemiparesis, and this is the same gentleman who has, from the rural background, has come up completely dressed up, well dressed, well groomed, and had come to the hospital without any support. So just a few examples how acute stroke management can lead to a dramatic, fruitful change in the patient's outcome. Who can have a stroke? 1 in 6 people are at risk of a stroke. It's not that only elderly will have a stroke. It's not that only patients who have hypertension will have a stroke. Stroke can occur to anybody at any age group, and almost 25 to 30% of strokes are around below 50 or below 40 years of age. We have seen a stroke as young as 21, 22 years of age. We have seen a stroke above 95 years of age, of course, but it can happen to anybody. So we all know that the stroke is of two types: ischemic stroke, which is due to obstruction to a blood vessel, or commonly called as clot in the brain, or hemorrhagic stroke, which is usually due to bleeding in the brain due to rupture of a blood vessel. So I will just show you a few CT scans. This is a normal CT scan of the brain. This is the lower part of the brain, and this we are going higher, 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 and this is the upper part of the brain. And what you can see is that these are some ventricles, and crossly it's this gray granular appearance of the brain. In a bleed, a very simple thing is, if you see something like this, which is white, almost bone-like white, it is a bleed in the brain. If it is a bleed in the brain, you can't thrombolize the patient. There are other treatment options available. So what you can see here is a bleed in the brain. What you can see here, the same CT scan, it's a bleed in the brain, which appears white. This is the right half of the brain, this is left half of the brain. And this is a clot in the brain. If there is a large clot, instead of that granular gray white appearance, that part of the brain will become almost darker gray or constant gray, like this. However, if the patient has stroke onset, say less than 6 hours or 10 hours, and if it is a ischemic stroke due to clot in the brain, of course, you will not find a hemorrhage, but you will not find this thing also. Usually the CT scan, definite CT scan changes come at least 10 to 12 hours after the onset of the symptoms. So 80-85% of the stroke patients, which are ischemic stroke patients, can have a normal CT scan immediately after the onset of the patients. And a normal CT scan does not mean they don't have a stroke. It does not mean that they don't require immediate treatment. So this is a normal CT scan. Anything white, it's a bleed. Anything gray, it's a stroke which is at least 12 hours more than that. If the patient has clear stroke symptoms and a normally appearing CT scan, he can be a candidate for immediate clot bursting therapy. So we will go into the details of this clot busting therapy later, but before that, you all know about the stroke symptoms, but I will be again re-emphasizing on the stroke symptoms. So this is the data. Every 6 seconds stroke kills someone. Every other second stroke attacks a person. Almost 17 million people suffer from a stroke every year. And these are not mere numbers, these are real people. And it's a leading cause of death in India. So we all know about the symptoms of a stroke, and there is a worldwide campaign which is called a FAST. We have a Hindi version which is called a Bachav, and we try to promote the recognition of stroke symptoms. And it's a very simple mnemonic: face. If anybody has drooping of the face, along with a drooping of the arm, if the patient is not able to grip properly, if the patient is not able to lift his or her arm above the head, or any speech change. There's slurring of speech, there's difficulty in naming things, there's difficulty in word finding, there's some confusion when the patient is doing some activity. If any patient has 2 out of these 3 symptoms, chances of having a stroke is almost 80%. If anybody is having 3 of these symptoms, possibility of stroke is more than 90%. So you will not be making any error on the wrong side. The patient will be having a stroke. But if there is only facial drooping without any arm weakness, or without any speech change, patient is probably not having a stroke. It's possible that patient is having a facial weakness or Bell's palsy. So most of the time, patients with Bell's palsy panic, but somehow stroke patients don't panic. I don't know why. But isolated facial drooping is not a stroke, but facial drooping with arm weakness or speech difficulty, likelihood of a stroke is very high. It's time to reach a stroke ready hospital or a place where a stroke treatment is available. The same thing, abnormal facial, means facial weakness, weakness of the right arm here, and fast face, arm, speech, time to call or reach a hospital. Bachao. ब से बाहा, चा से चेहरा, आ से आवाज, वा से वक्त. हिंदी mnemonic of fast is बचाव. ब से बाहा, चा से चेहरा, आ से आवाज, वा से वक्त. अगर किसी को बचाव के 3 सिम्टम्स हैं तो वक्त है कि आप जल्दी से जल्दी हॉस्पिटल भागें. So इसके अलावा भी there are other few things also. Some Cincinnati pre-stroke scales are there, but fast is a very small thing which paramedics, hospital staff, everybody should know about. So why is all this halla about reaching the hospital fast? Why is it that we have to do this therapy within 3 hours or 4.5 hours? Because time is brain. When a person suffers a stroke, on an average, 1.2 billion neurons are lost. Every delay, every 1 second delay leads to a loss of around 32,000 neurons. Every minute delay leads to a loss of around 1.9, 20 lakh neurons. So each and every minute is important. If you are able to expedite your therapy by a minute, you will be saving almost 20 lakh neurons in the brain. And every minute of delay can accelerate the patient's aging by 3 weeks. So it's not neurons only, it converts into the patient's age also, it's outcome also, life outcome also. So each and every second is important because as the time keeps on increasing, more and more brain keeps on getting dead. So what happens when you have a stroke? If a patient has a stroke, there is this blue area which has already lost its blood supply. And whatever I do in the world, I will not be able to save this blue area at all. However, there is a surrounding area which we are calling as penumbra here or oligohemic area that is having blood supply which is significantly reduced and inadequate. So if somehow we are able to start the blood supply to this green area or the lighter green area, we will be able to save a lot of brain and lead to improvement. Patient's symptoms are not because of this blue area only. Patient symptoms are due to this whole area. So if you are able to rescue this area, definitely there will be improvement in the patient symptoms. But the symptom due to ischemic area will definitely remain. But any delay, if we keep on delaying the things, the ischemic core keeps on increasing and the penumbra and oligohemic area become completely ischemic. And after a certain time, there is no point in restoring the blood supply. So we have to save the penumbra to have a fruitful outcome, and to save the penumbra, time is important. So the same thing. This is the ischemic core and this is the area which is possibly at a decreased blood supply. And if we save this blood supply, the patient will have a significant improvement. So why do we always fight for stroke treatment? There are multiple issues involved, and you all would have faced it at some point of time. The barriers to stroke treatment in India include reach. Patients don't reach hospital at time. Before that, the patients don't recognize the symptom. And after that, they don't reach the hospital in time. Reasons are multiple. Patient may be from a rural background, not having any conveyance to reach a hospital. Patient may be living in an urban area, but an elderly person living alone may not be having a support system where his stroke symptom recognized, he is carried to the hospital immediately. People from the rural background still believe in places like Bambawad, where there is a Baba who gives jadi booty to each and every person who comes to him and says that nothing else is required. And everybody knows that we believe more in Babas and jadi booties than scientific treatment. So that is also a big barrier. People reach hospitals which are not equipped to treat stroke patients. And of course, awareness has talked about. If you are not aware of your stroke symptoms, if you don't know you have a stroke, you will never recognize stroke. And still today, worldwide, hardly 10% of the patients reach in time, and in India, probably that number is even less than 1%. So patients don't recognize and they don't reach the hospital in time. So barriers cannot be broken in a day or in a year or decade. It takes time, and we have been constantly working almost for the last 20-25 years to improve stroke outcomes. So if a patient reaches a hospital, which is a stroke ready hospital, this is what happens. And this 60 minutes is wrong. We are doing it in 20 minutes, 30 minutes. You suspect a stroke patient, is immediately evaluated by the doctor in the emergency room, which includes the blood pressure, sugar, is immediately shifted to a CT scan within 10 minutes. CT scan is evaluated, even if it is 12 in the night, the images are shared on WhatsApp, and the decision to thrombolize is taken after discussing with the patient's family, a consent is taken. And most of the time in metro hospitals, we have been able to do this in 30 minutes to 40 minutes of landing, or even 20 minutes, 15 minutes at times, depending on a number of factors. So what we are able to do is being done at a very few places in most of the cities. And of course, when I'm talking about most of the cities, I'm talking about metros, big cities only. So, but with constant effort, even Dr. Shruti here in Metro Hospital has been a part of this team, and she has been a person who has recognized stroke when she was in emergency and taken a call that this patient probably needs thrombolysis. So it's not the doctors or the nurses only, it's a training program for the whole hospital. We even try to teach our ward boys or guards that if they recognize a patient who is coming and they recognize a stroke, they have to hurry up and they can't delay the patient. So any patient who is not having a bleed in the brain, which is immediately diagnosed on a CT scan, is a candidate for thrombolysis therapy. And if there is a bleed in the brain, of course, you can't give thrombolysis. There are multiple things beyond thrombolysis also which can be done for acute stroke care, which I'm not going to discuss presently. So rapid evaluation and rapid treatment, blood glucose, ECG, you have to establish the time of onset. That is very important. And if possible, take relative or carer to the hospital as a source of information. Means you just take, if you have a stroke at home, if you recognize that somebody had a stroke at home, you don't have to give aspirin as you do the usually in patients who have a heart attack. Thing is, recognize the symptoms, make arrangement of shifting to the patient to a stroke ready hospital. When you're calling the hospital, tell them that the patient possibly has a stroke so that the hospital is ready even before the patient is coming. So what we see is that this is the data which has been compiled over a large number of years, that if you are able to thrombolize the patient within 90 minutes, 1 out of 4 patients will have a significant improvement, that is independent living. If you thrombolize in 180 minutes, that is 3 hours, the same number is around 8 to 9. So that is why doing it early, doing it fast is the most important thing. So there are complications of this therapy of thrombolysis, and around 2 to 3% of patients can have a life-threatening bleeding in the brain, but more than 60–70% of the patients will improve when you thrombolize the patient. And now it is, earlier, a few years back, the time was 3 hours, but now it is almost 4.5 hours. And this is what we show to the patients or families when we are trying to convince them that we need this therapy. That suppose 100 patients have a stroke, 2 or less than 2 will die, but almost 65% patients with thrombolysis will improve. If you don't thrombolize, the same number will be around 30. So this is the only therapy which is available, and it has to be done now. You can't decide 15 minutes later or 30 minutes later. We have to take a call immediately. When we say you have to take a call within a minute, then they decide. Then they take 15 to 20 minutes. So you can't say that हम 3 घंटे का टाइम है. टाइम अभी है. जितना हम डिले करेंगे उतना नुकसान बढ़ता जाएगा. इसमें हमारे पास सोचने का टाइम नहीं है. So acute stroke care starts with recognition of the stroke, emergency care, IV, TP or tissue plasminogen activator, ICA, ICU care. Intervention may be required, but rehabilitation is the pillar of stroke care after a few days. Patients have to, we start rehabilitation assessment, which includes swallowing assessment and rehabilitation in first 24 hours of admission for each and every patient. And as per their needs requirement, it's possible that you are not able to do a very active program, but mobilization, passive mobilization, chest physiotherapy to active mobilization, gait training, swallowing assessment, everything is started in the hospital with a plan for the post-discharge care at home also is given to each and every patient. With this, I would like to thank all of you, and I will request to answer any sort of questions, not only to stroke, whatever neurological issues I can try to answer, I will try to. Thank you.
Thank you, sir. Thanks a lot. It was, hello, am I audible?
Yeah.
Sir, it was really nice and very well briefed, and I'm sure as a physio next time getting the clinical scenario, we will be in a better position to assess, judge, and do the rehabilitation part of patient. Sir, there are many questions, and a few of those I would like to put in front of you. One of those even I was very excited to ask was that if you can share some situations where intervention of physiotherapist really bring the change in the patient.
So where physiotherapist can make a change?
Yes, sir. Or any of your experience where you have seen that physiotherapist intervened and that really helped the case.
So your question is a very understatement. I don't say that there are a few situations where you can make a change. What I believe in my patient is that each and every stroke patient, my role is just for the first few days. After that, every role is being played by physiotherapist. So if the patient is not swallowing properly, the role starts on day 1. We have to do swallowing assessment. We have to start swallowing exercises. And who wants to be fed by a tube? And if we are able to start swallowing exercises from day 1, and the swallowing improves with just few basic exercises, movements of the tongue, movements of the cheek, other facial muscles, and patient starts swallowing, it's almost miracle for the family. And this is something which I am not able to do. This is what the physiotherapist only do. And from day one, the patient starts walking, it's possible patient is having residual spasticity. It's possible that patient is not motivated enough to walk without support, though he can walk without support. It's possible that patient can move on a level ground, but he has got a lot of difficulty in proximal muscle. He can't get down the stairs. And each and every such part is taken care by physiotherapists. It's not me who is guiding in those patients. It's the physiotherapist who give a feedback to many patients who are not able to visit the neurologist, but it is the physiotherapist who is talking and saying, "Ki ji, itna improvement aa gaya hai. We are able to do this." And means it's not a means after a certain time, physicians, neurologists have a passive role. My father had a stroke 1 year back. I meet him once in a month or maybe twice in a month. He doesn't live with me. But there's a physiotherapist who is taking care of him. And except for the last 2 to 3 months of COVID, he is the person who has been taking care, who has been making him walk, his exercises, his grip, everything is being done by him for the last 1 year on a daily basis. So role of a physiotherapist is beyond words in a stroke patient. Maybe a fracture patient will not need a physiotherapist after a few months, but a stroke patient, what I say is when the patient improves, I don't say you stop physiotherapy completely. My advice will be keep going to your therapist, to a rehabilitation expert at least once a week, so that whatever the strength, whatever the dexterity you have gained, there will be some improvement. That person has been assessing you constantly, and he will of course be able to come up with something new for you, some more exercises for you, so that your strength, dexterity, quality of life keeps on improving. The role cannot be defined because it's extensive, as simple as that.
Thank you, sir. I'm sure that would be very motivating for many of the physios. There is one more question that many of the people have asked. That, sir, do you define any golden time for physiotherapy of a patient of such kind, like 6 months, 1 year? Golden time that within this frame of time, maximum recovery is supposed to become. Is there any golden rule or golden time?
No, there is no golden rule. We all know that the most of the patients have maximum recovery say in the first 1 month or so. And if there is a residual weakness after a month, there will of course be, the course will be very slow. Spasticity will set in, some muscle atrophy will set in. If that 1 month has not been good, contractures will set in. But it does not mean that you stop making your efforts after 1 month. Suppose a patient has left hemiparesis and he has started to walk with minimal support. He has started to do his daily chores, but with difficulty, and there is spasticity. So if you stop therapy after a month, his spasticity will keep on increasing and he will end up having contractures. So you can't stop even after a month. What usually happens is the patient gets demotivated because they are not seeing any further improvement. So we have to be a little realistic. We have to be a little understanding that it's possible that we are not gaining any visible or gross improvement, but it does not mean that this rehabilitation is not going to help you. Something being done. When there is lack of motivation, physiotherapist is the only person who is going to motivate the patient for further treatment, further exercises, further movements. So I will not say if a patient has become completely independent or minimal dependence, maybe you can quit, but there's no rule of 1 month, 6 months, 1 year. I gave you an example of my own family. It has been 1 year, but we constantly are taking help of a therapist.
Thank you, sir. I think there is one more question floating around on YouTube, and I think you have already answered that. And the question was that the motivational level of the patient in such cases are very low. And secondly, people have also asked about the apprehension which most of the time patient shows about पैर टूट जाएगा, मैं आगे रखूंगा तो गिर जाऊंगा. Sort of queries and apprehensions are often shared by patients. So the question was, sir, that how would you suggest a physio or any part of rehabilitation team to deal with such situations?
मैंने पिछले 15 साल में फिजियोथेरेपी की वजह से किसी का पैर टूटते हुए नहीं देखा. ठीक है, और हाँ पैर टूटते हुए देखा है पेशेंट्स के फॉल होने की वजह से. बाथरूम में फॉल होने की वजह से, बिस्तर पे फॉल होने की वजह से, लेकिन फिजियोथेरेपी की वजह से मैंने आज तक किसी का फॉल होते हुए नहीं देखा। आई डोंट मतलब बिलीव के फिजियोथेरेपिस्ट की वजह से या उसके ओवर एग्रेसिव होने की वजह से किसी का फॉल हो गया। ये सुना है कि IFT दिया था, स्किन पे बर्निंग हो गया, विच इज एक्सेप्टेबल, ठीक है। कुछ लोगों ने ये भी कहा है कि जी अल्ट्रासोनिक से कुछ हो गया, विच आई डोंट एक्सेप्ट, बट ठीक है जी, पेशेंट कह रहा है, आपको मानना पड़ेगा। थिंग इज कि मुझे नहीं लगता कि ज्यादातर जो फिजियोथेरेपिस्ट जो एक्टिवली पेशेंट देख रहे हैं उनकी वजह से पेशेंट का कोई फॉल हो जाएगा। हमको थोड़ा सा बैलेंस करने की जरूरत ये जरूर है कि आपको ये असेस अगर आप ठीक से कर रहे हैं कि पेशेंट की क्या मसल स्ट्रेंथ है, क्या वो मूवमेंट कर सकता है, तो उसी से आप आगे लेके चल रहे हैं, तो इट कैन नॉट हार्म यू। यूजुअल प्रॉब्लम इज दैट स्पास्टिसिटी इज देयर व्हिच इज ओवरलुक्ड, जो मेरा फीलिंग है। मे बी people who are taking care of stroke patient very regularly are doing it properly, but कुछ मसल्स की स्पास्टिसिटी स्ट्रोक पेशेंट में ज्यादा डेवलप होती है, जिसको कि हम इग्नोर कर देते हैं। एडक्टर्स ऑफ थाई आर यूजुअली स्पास्टिक, व्हिच वी डोंट टेक केयर ऑफ। सुपिनेटर्स आर यूजुअली स्पास्टिक ऑफ अपर लिम्ब, जिसकी वजह से हाथ यूजुअली इस पोस्चर में आ जाता है, जिस पे हम ध्यान नहीं देते हैं। सुपिनेटर इज अ बल्की स्ट्रांग मसल, सो इट डज नॉट मीन कि इनकी वजह से स्पास्टिक होने की वजह से फॉल हो जाएगा। हाँ, ऑफ कोर्स और चीजें जो घर में होती हैं जिसमें हम ध्यान नहीं देते हैं, फैमिली ध्यान नहीं देते हैं, कि रूम में जहाँ पे पेशेंट है वहां पे बहुत सारा फर्नीचर है, रग्स हैं, मैट्स हैं, बाथरूम के अंदर सेफ्टी मैकेनिज्म नहीं है, जिसकी वजह से गिर रहा है। बट थेरेपी, फिजियोथेरेपी, रिहैब विल नॉट लीड टू एनी फॉल, डेफिनेटली नॉट।
Thank you, sir. There is one more question. I think this is more about the concern of the patient than a physiotherapist. People are asking that during this corona pandemic, is there any change in the rule, or is there anything which they need to take care of before coming to the hospital in case of acute stroke?
So most of the patient hospitals which are providing acute stroke care, like Metro Hospital or other hospitals, are taking all the precautions which are required for each and every patient. And despite COVID, there is no delay in the treatment of the stroke patients. Last week only, we thrombolized a patient at 4:15 in the morning. I'm talking about this Sunday only. I mean, yeah, this Sunday only, 4 days back. And he was thrombolized within 40 minutes, 30 minutes of landing in the hospital, which included doing a CT scan, going from home to the hospital, talking with the family, and everything was done. So if you are reaching a hospital which is taking care of the stroke patient in a routine manner, it's safe for the patient, family, doctors, staff, without any delay in the treatment of the patient. And I'm not talking about my hospital only. I believe most of the hospitals are able to do the same thing, whether it is in Delhi, Noida, Gurgaon, anywhere.
Thank you, sir. Rest of all comments are all about that how well you have explained them. Many of them are wishing you good evening. Many of them are thanking you for so nicely explaining them the technical details of the cases. And I think I have summed up all the questions in the given three. Shruti ma'am, it's over to you now if you want to say something.
Me?
Shruti ma'am, are you there? Shruti ma'am, can you hear us?
Hello. Yes, sir.
Yes, ma'am. Can you?
Yes, sir. Sir, good evening. Sir, do you think in the rehabilitation or in an emergency team, physiotherapy should be there while assessing a patient?
Dr. Shruti, sorry, I missed your question.
Sir, in emergency, in a first case, do you think physiotherapy should be there in a team to assess a patient?
No, I don't think so. So the physiotherapist is not required in acute stroke patient who is coming to the emergency. And of course, we have to recognize a stroke, and that person can be a physiotherapist, that can be a nurse, that can be a doctor, irrespective of that. But after the first few hours of the treatment, when the patient is in the ICU or when the patient is in the ward and when the patient immediate first 5 hours, 6 hours has been taken care of. Then the need of the physiotherapy starts, which starts from swallowing assessment.
Sure.
So I think it was a very nice and conclusive session, sir.
Excuse me, I would like to add what sir have said about the acute rehabilitative or acute stroke patients. Actually, what I have come across in various research is that it is very important in the first 24 hours after a stroke, physiotherapists begin rehabilitation in short, frequent spells. And it focused on the getting out of bed, standing and walking, which is very important in first 24 hours. And also this repetitive task training helps in people regain movement and relearn
I got
everyday
disconnected,
activities.
but I missed a few questions, sorry.
I think, sir, there is a confusion since Shruti ma'am asked you about the assessment and
I
probably
am back now.
So it was, sir, a discussion about whether a physio should be there in the
Yes,
emergency.
as you were
Anshika
saying
was giving her input about that in first 24 hours, many researchers have suggested
yes, sir.
there is
I'm
a
talking
role
about the
of
acute.
physiotherapy.
I'm talking about the role of physiotherapy in acute stroke patients. Sir, various researchers have suggested that it is very important to begin physiotherapy rehabilitation in first 24 hours only in stroke patients, because it includes like short frequent spells of rehabilitation, then focused on getting out of bed, standing and walking. And this repetitive task training helps people regain movement and relearn everyday activities. So these things are very important in first 24 hours, that is in the acute phase of a stroke.
Absolutely, absolutely.
So I think physiotherapist should be included in the first 24 hours in the team.
So Dr. Anshika, that's what I am saying. I'm not saying that they should not be included in the first 24 hours. What I'm saying is that the emergency treatment in the first 5 to 6 hours, maybe our physiotherapy is not required. But after that, once the thing has stabilized, in the first 24 hours, we have to start assessing the swallowing part, the speech part. And of course, then the role of physiotherapy becomes very important. So not in the emergency, but after emergency, definitely rehabilitation is a very important part of the care. And when we are talking about rehab, just for example, this WSO award, which I was talking about in the initial part, two parameters are there, which have to be fulfilled. Swallowing assessment in the first 24 hours and post-stroke rehabilitation in the first 24 hours. If you have not done it, you don't fulfill their criteria.
Yes,
So
yes.
we are doing assessment, swallowing score in each and every stroke patient. Dr. Shruti knows it. So, and therapy, rehab assessment is done in each and every stroke. Even as a patient is walking independently, we do an assessment, as simple as that.
Okay, thank you, sir.
Thank you, sir. Thank you very much. It was a very nice session. Really, I learned a lot. Thank you, sir. And thank you, Manas. It's a very really informative session. Thank you very much for your time.
On behalf of IAP technical team, thank you, Dr. Kapil Singhal sir, and for a wonderful session, and all participants for attending this webinar. I would also like to thank Dr. Sanjeev Jha sir and Dr. Ruchi Vashne ma'am for providing a platform for sharing the knowledge. I request to all participants, please subscribe our YouTube channel and follow our FB page. Thank you. Have a nice day. Thank you.